This man came from Kentucky with black lung disease. We were trying to help him figure out if there was something we could do to improve his life. And he flew uphill, of course, to get to Denver and went directly to clinic from the airport, where I saw him almost as soon as he got in the door. He was huffing and puffing and his lips were blue because he was mile high and he had a serious lung condition. And I said to him, we can't have you feeling like this. And in this kind of extreme situation, in outpatient setting, to do the workup, I need to admit you to our hospital. So I wrote the orders out. I got my nurse involved, I set it all up. Came back 15 minutes later and he's still sitting in the waiting room and looking much worse. And I went in to inquire what happened here. Why didn't he get admitted to the hospital, like I said? The answer was the business office wouldn't let him be admitted to the hospital. He'd come to Denver approved for an outpatient experience, and they would not allow him to go inpatient. And at that point, I thought, I'm at the world's best hospital for lung conditions, and this guy needs our help, and I can't make it happen.
Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1945, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and from around the world. Please note that the opinions and ideas shared on this podcast are those of the speakers, not the opinions of the Ogden Surgical Medical Society or its board. While medical topics will be discussed, it is not to be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice. I want to introduce myself again. I'm Clark Madsen, one of the hosts of this podcast. I'm a family physician and sports medicine physician here in Ogden. And today I'm joined by my partner.
Hi, I'm Scott Moore. I'm a pathologist and lifestyle medicine physician. I teach medical laboratory sciences at Weber State, and I do some clinical research as well.
Yeah, we're really happy to have some really amazing guests here today. We're joined today by Dr. Jarvis and Dr. Baranko, who are both experts in their fields and are here to kind of talk about a very important topic that affects all of us here in medicine. And so I want to just say welcome to the podcast. It's good to have both of you here with us. How are you doing today?
Thank you. We're happy to be here.
Yeah, thanks. Let me introduce myself because I think you know Brent pretty well, but I'm kind of the stranger. I don't live here in Ogden. I live in Salt Lake City. I trained at the University of Utah, got my MD there, but then stayed for residency and for fellowship. The residency was family practice. And then I received a master's in public health while I was training in both public health and preventive medicine and occupational and environmental health. My career has been primarily in public health, although I've practiced family medicine for a while. And the last time I was clinically active to actually had patient care responsibilities, I was at National Jewish Center in Denver, taking occupational lung cases. I enjoyed the invitation.
Yeah, we are so happy to have you guys here and really talking to our members, because I know for me, especially in America, it's a little strange when I start hearing about single payer healthcare. And that's really been something that I've been hearing a lot more. It seems like I hear a little bit more about it every single year. So what's going on with single payer healthcare?
Yeah, single payer healthcare is gaining more traction in the United States simply because of the shortcomings in our values, not being able to cover citizens, and the exploding costs that are occurring in healthcare. And in the last few years, there's been some significant changes. It started, I think, with the American Medical Association about 4 years ago, when they removed from their language in opposition to single payer healthcare at a meeting in Chicago. And in 2019, the American College of Physicians, representing 160,000 physicians in the United States, came out with a position statement advocating for single payer healthcare. More recently, the American Public Health Association came out in support of single payer, and the American Medical Student Association came out recently in support of single payer. So there's a lot of changes occurring.
It sounds like there's a lot of support too. And now how does the support, is that support just simply these big institutions, or is it actually like the individual physicians? And what kind of benefits could it provide us and our patients?
I think that's why I am so interested in talking to you today, because I want to tell you my journey. How did an orthopedic surgeon who's king of the reimbursement pyramid, how did I come to support single payer healthcare? And it's an interesting journey that starts a long time ago. But before I tell you the story, I kind of want to set the table with some economic facts. Have you seen the recent Capital One commercial? It's on audio and on TV. And it profiles the Antonelli's cheese shop in Austin, Texas. And the very last line of the commercial is what they do with their 2% cash back. And you know what they do with their 2% cash back? They spend it on healthcare for their employees. And it's kind of a feel-good commercial, but I'm like, it got my attention. I'm like, my God, these hardworking people, the business owners, why are they spending their 2% cash back for healthcare?
It's kind of one of those things that's always kind of boggled my mind, how much we're willing to spend, not just in taxes and stuff for the government, but then we have to go above and beyond and spend a huge portion of our income in our healthcare, and it without any assurance that we're getting what we paid for back. And so that's I can say that I think all of us have thought about this from time to time, and we're really interested to see your take and experience as you've gone down this journey.
I'm glad you brought up the tax structure, because Americans are the most taxed citizens in the world for healthcare. Now, we don't have the highest tax rates. I'm not saying that. Other nations tax their citizens at a higher rate. We tax ourselves more for healthcare than anyone else does. We have more per capita taxation, public revenues going to healthcare than is the total amount going to healthcare in any other first world country.
And is that money going to pay for uninsured care, or is that, on top of everything we're already paying for health insurance?
So we Americans tend to think of that amount that goes to health insurance, because we see that in the paycheck stub every 2 weeks. We think of that as the big bolus of money that we have to worry about and take care of. Actually, that is a much smaller pot of money. It's an order of magnitude less than the pot that comes out of the paycheck in the form of state, local, and federal taxes that support the care of public employees and their dependents, that supports the care of senior citizens through Medicare. It supports private health insurance through the employer tax credit, which is the largest single line item in the federal budget. It's not true that we have a private healthcare system. We have a publicly funded healthcare system.
And throughout the United States history, beginning with Teddy Roosevelt and the Progressive Party, there have been attempts for the United States to embrace a national healthcare system, but it's always been squashed by the business community. And the business of healthcare is now eroding the experience of giving and receiving care. Physicians, I think, used to fear government intrusion into their profession, but really what's happened over time is insurance companies and the business of healthcare have supplanted the concerns about government intrusion. And now most healthcare professionals, or many of them, fear the insurance companies and how they intrude into our ability to care for people. There's an elemental problem with business and healthcare. And if I may, in a normal free market, consumers have full knowledge of what they are buying. They face the full cost of what they are purchasing. They have the time and ability to deliberate and make rational decisions. They have options for where and from whom to make a purchase, including to not make a purchase at all. A well-functioning market has many buyers and sellers. No single party has control over the prices. And this is the invisible hand of the market based on supply and demand and what people are willing to pay. But healthcare does not follow any of these traditional norms. I did not become a single payer advocate overnight. It took me a long time. But what I just read to you about the market and healthcare delivery and what's occurring in this country, it resonates with me. And we see the shortcomings of it every day, the moral failings that it causes.
Now we talk about moral failings, and one argument that I have, or that I've heard other as well, is won't national health insurance, isn't that like socialized medicine, and won't that lead to increased rationing and longer wait lines?
We have wait times right now. We have many wait times. I can tell you the story of a woman I met this year who needed a knee replacement. She was no longer able to work because her knee hurt so bad. She was a very proud individual, but she had no health insurance. She ended up dying in her car in her friend's driveway, awaiting approval for Medicaid. Autopsy suggested that she had a massive pulmonary embolus. I can tell you many stories about wait times in this country. What we want is universal coverage, comprehensive coverage at an affordable price. It will reduce inequality in the country, and a universal system in this country would be an anti-poverty measure. It would help lift people out of poverty. Even just driving into work this morning on the radio, I was listening to CNN, and what were they profiling? Teachers and a national teacher shortage. And what were the big issues for them? They're not getting paid enough. They have second jobs and healthcare costs. Our healthcare system is regressive. My family plan, I pay the same for my family plan as a school teacher making $50,000 or $60,000. It's a bigger bite out of their budget than it is for me.
So it's no national health insurance or state-based health insurance, which is another possibility. It doesn't have to be a national plan, is not socialized medicine. Socialized medicine is when the government owns the means of production, the hospitals, the clinics, everything, salaries, and employs the professionals, the doctors and nurses, et cetera. And there are systems like that. The United Kingdom has a socialized health system, the National Health Service, which they're very happy with, by the way. That's not what's being proposed.
Well, what we want is a single financing system. One, we want to take over of the insurance industry to have one seamless, efficient, streamlined financing system.
It's public funding for private healthcare delivery. That's what it is.
And I think that's an interesting point that's oftentimes missed in these conversations, because you think the UK model, for example, where physicians and everyone's employed by the government, but here we're kind of talking about there's lots of different options, and one of them would be just having everyone being able to keep their current role. It's not you being bought out by the government. And that seems kind of a unique distinction. Are there countries that do that currently?
Sure. Canada has a public funded healthcare system and private healthcare delivery. Physicians in Canada bill fee for service for their services. Provinces are in charge of that. The national government does a lot of the funding in Canada, but the provinces actually do the policy and the regulation and the control of how to distribute those funds. So yeah, that's an example.
Doctors Madsen and Moore, everybody listening to this podcast, a healthcare professional, knows some of the shortcomings of our system. But what I'd like to share is just a couple economic facts, what's going on in this country, if I could, that'll really get your attention. So on average, a person in the United States now spends more than $12,000 per year for healthcare. And in comparable nations, it's only $5,700. In 2020, 19% of the gross domestic product in the United States was spent on healthcare. The next highest country was Canada, 13%. 2 of the top 10 Fortune 500 companies are in healthcare. CVS was number 4 on the Fortune 500 in 2021. United Healthcare is number 5 on the Fortune 500 in 2021. United Healthcare made $17 billion in profit last year. Private equity investment in healthcare went from $5 billion annually in the year 2000 to $100 billion annually now in 2018. The median launch price of a new drug in the United States soared from $2,115 in 2008 to $180,000 in 2021. I can continue with economic facts, but why are we seeing an explosion of healthcare costs? Is because There's dividends to be paid. There's money to be made. And the fact of the matter is they can do it. And therefore, because they can, they will, and they do so.
Thank you so much for sharing those stats with us. I'm kind of interested as we're talking about money. I'm thinking about, how solvent the system actually is. And is it just that we're paying ourselves, or we're paying physicians and we're paying other practitioners more than we need to? Or are we paying ancillary services like people behind the desk, the back offices? Are we paying those people too much? Or are we spending too much on them? And then we also have like kind of an aging population, and will that bankrupt the system? I'm just thinking about these financial topics, and could you shed some light on those for us?
There are other societies that pay far less per capita, and they're in the first world. They pay far less per capita for healthcare than we do, or far less percentage of their gross domestic product than we do for healthcare. And they have a population that's much older than ours is. So it's not an aging phenomenon, no. And Canada, which we've already described as a place where they do public funding for healthcare, but private healthcare delivery, the net income for physicians in Canada is no different from American physician net income. But what's important about that comparison is those physicians in Canada don't have anywhere near the overhead to pay for their practices that American physicians struggle to maintain. All of that is quite a bit different when it's a very smooth, seamless, single payer way of paying for the care. Now, what we have in the United States that causes high cost is waste, administrative waste. We waste $500 billion a year on the private for-profit health insurance business model that is the most wasteful way ever invented to finance healthcare. That is the significant underpinning of the statistics that Brent just described to you.
One of my more favorite books that I've read as I've educated myself over the last decade, I finished it and I bought copies of it to pass out to people, but it's Medicare for All, A Citizen's Guide by Abdul Al-Sayed. He ran for the governor of the state of Michigan, ran on a single payer platform. He obviously did not win, but his book really goes into detail in very simple speak about why we have high prices, the collusion that occurs between hospitals setting prices and insurance companies. And it's a very warped system with misaligned incentives, and it's complex.
If I may, I want to kind of address this more. We've talked kind of the big structural issues. I'd like to focus us a little bit on more of the individual patient. I honestly, just a few months ago, had a patient who I was struggling to get a referral for, who had a fairly urgent procedure that they needed to get, and was struggling to get an authorization for a referral for the patient, to the point that the patient kind of disappeared. And when I finally caught up with him, he informed me that he attempted the procedure on himself and was doing fairly well at the time, though this procedure did have the potential for some significant comorbidities. So that's kind of an example of the worst case scenario in our current system. In a more universal system, what would the patient experience be like? How would they experience the healthcare system differently than they do now?
So automatic enrollment, cradle to grave. You're never disenrolled. You're a resident of the region where the single payer operates. You're part of the system and you have a card. You have choice about physicians, any physician. You're free to go to whatever hospital that's part of the system. There are no panels. There is no exclusionary policy. A benefit package is determined globally for everyone. So it's well known what's covered, and vision and mental health services and addiction recovery services, which are now very poorly covered because they're not remunerative, would all be easily included within the budget of such a plan. So you have your card, you want to see a physician, you go see the doctor. The doctor bills simply to the single payer, and the guarantee is that the bills are paid as soon as they're received. No overhead, no big billing staff, none of that. You need to be hospitalized. You go where your physician has privileges and where they admit you, and you're taken care of. The patient care is the reason that the hospital exists, not the profit taking. So it's an entirely different experience. The striving is to try to meet the clinical standards that we have created, many of which have been created in the United States. If you come with chest pain to the emergency room, you should be getting an aspirin tablet. Well, that will be the focus, not asking the first question, which is what's your insurance, and diverting people away and treating them differently depending on what the wallet biopsy says. No, what do you need? What's the first priority? Who are the patients that need treatment sooner? Well, that's the focus of a single payer system. Patient care drives everything.
And single payer is assuming this country embraced it like Medicare. Let's say there was a national movement and the country demanded it. We just became too fed up with the whole system. A single payer system could be designed in any way we choose. There would be a lot of people at the table, but there's a lot of things to be sorted out. Most studies, when they look at the big picture, when they look at would it cost us more or would it cost us less, most of the big studies, 24 to 25, if I remember right, that have been reviewed, they come out in favor of single payer. As the first couple of years, it would be a tumultuous transition, no doubt. But what happens over time is that you start saving money. It's interesting that Ronald Reagan, champion of the free market, what did he do during his presidency? He recognized that Medicare was going to go bankrupt. And what did he do? He capped reimbursements to hospitals initially, said, we will not pay you more than X for this code and this admission diagnosis. And some years later, what did he do? He didn't let the free market play out. He capped surgeon fees for Medicare and he established price controls. So we need a little bit better control over our healthcare costs. And that's how a single payer over time becomes much more attractive, saves money.
I really like how you brought in the financial piece, you brought in the patient care piece. It sounds like a real good deal. So what about the future? Being a researcher myself, will a publicly financed system perhaps stifle medical research? Could there be less funds available for excess funds to be available to do research? I'm just not familiar with that.
Approximately 60% of drug discoveries are going through research institutions, universities. The other 40% roughly are through private labs and things like that. But it could be set up in any way that you want. So one thing that would happen with the transition to single payer is we wouldn't have Me Too drugs. We have a lot of drugs, a lot of statin drugs. We have a lot of blood pressure drugs. And we have those drugs because they can make money. So that would change. Also, with healthcare savings, let's say, right now, the government just passed the Inflation Reduction Act, and Medicare was included in that to negotiate drug prices. It should have been done a long time ago. And unfortunately, it's only going to help those on Medicare. But one thought that has emerged is you could take all that money that you would save with a single payer system, and the government could spend it on innovation, research, grants to help these companies develop drugs that are needed. It's wide open. There's a lot of creativity that could come down the road in the future, but I still think we would be a leader in the world, innovation, have great researchers and labs. I don't think we would just stop developing drugs.
Innovation in healthcare occurs at the same per capita rate, meaning new ideas, new publishable research happens at the same per capita rate in nations which have public funding for private healthcare delivery as that happens in the United States. It's absolutely a false statement. It's a false flag, a pink flamingo, if you will, that people chase around all the time, that somehow we're going to lose our innovative edge. It's one of the ways they try to throw cold water and trade heat for light in terms of understanding what's really wrong with our healthcare system. No, absolutely not. We're not going to give up innovation. But we will be smarter about it. And as Brent says, most of the research is already publicly funded.
We're talking about how the research goes, and that's awesome. I love how that happens, and in my experience, that is true. It's been publicly funded, and I'm wondering as well now, especially with your background, how do you feel that preventive medicine, and for all these conditions that we have, especially chronic conditions that we suffer from in this country, how does that relate to a single payer healthcare system? I have some ideas, but I just want to go beyond the financial benefits.
Prevention is a core part of trying to provide quality healthcare. It's not well funded in the current business as usual environment in the United States healthcare system. People don't get, for instance, cancer screenings at age appropriate times, often because they can't afford them. They have co-payments, they have deductibles, they have a variety of financial barriers that keep them from following those recommendations. In a publicly funded single payer system, everyone has the financing they need for those benefits. Everyone. If they need counseling for weight reduction, if they need mental health resources, all of those things are paid for. Brent's already talked about dental care. What a major preventive intervention that is. People should be seeing a dentist on a regular basis for the cleanings. And dental oral health is one of the major lacks of the American population, not because we're not wealthy enough to afford it for everyone. People just can't privately pay for it. And so that transforms, that particular part of the system transforms everyone. We're delivering a better quality product, taking care of people prospectively. That actually reduces the cost of care. I mentioned that we have administrative waste costing us $500 billion a year because we don't do care properly under a system that focuses more on whether the wallet biopsy is right or not. We have a poor quality system, and that there's quality waste. We are losing another $500 billion a year because we're not taking care of people the way they should be cared for. This transforms all of that. It's a dramatic change. We'll have a much healthier population and a cheaper population to care for because of it.
One of my favorite healthcare quotes comes from former CMS Director Don Berwick, who runs the Institute for Healthcare Improvement. But he has said, every system is perfectly designed to produce the results it gets. And what do we have? Poor quality, high cost. Our system needs a transformational change.
Our system is designed to maximize profit, and it sure does that. Incredible profits. We've only sort of kind of touched the surface of that, but that's a long discussion in and of itself. But that's what our system's designed to do. You can't have the maximum profits and also the optimal patient care. They're mutually exclusive. You got to choose. So far, we've chosen the wrong one.
I can say as a fellow family physician, one of the most frustrating things is knowing what a patient needs to do for their health and injury and disease prevention, but knowing that there's no way they're ever going to be able to do that because of finances or insurance or whatnot. It's extremely frustrating. As you've mentioned also, one of the biggest challenges is the initial hurdle of converting our system to a more universal healthcare system. How would you prep the country, or how would you kind of prepare or kind of ease people into a more universal system from where we are now?
I think coming as a private citizen and as a physician, I think we need to share our stories. We need to talk about it. As I go back, I want to share my story, because you talk single payer, all of a sudden your colleagues start raising an eyebrow. Like, what happened to Baranko? Did he go off the deep end? He's been smoking some on the weekends. And it's a long journey that did not come overnight. But just like the adoption of Medicare, there was a groundwell support for Medicare, and it overwhelmingly passed despite the opposition of the American Medical Association and other business interests. It will have to be a grassroots public groundswell demanding change and action, but there's a heavy lift that has to take place. There's a lot of education. We are feeling a lot of pain and economic stress as a result of this, and it's going to take a while for everybody to get there, but I think we can do it. And we all, especially as physicians, we should do it. We should talk to our patients about it and ask them to vote responsibly when they're thinking about their own health and healthcare needs.
I agree with Brent. You got to tell your story. I've written 2 books about health system reform in the United States. I just released the second one about 2 weeks ago. They're full of stories from my life. What brought me from a suburban, conservative raised American from the upper middle income class, always wanting to be a physician, to someone who is going around, literally around the country, trying to encourage legislatures and the Congress to approach this in an entirely different way. So The Purple World was the first book I released about this. That's from 2018. And then I just released last month For the Hurt of My People. And now I'm getting into film production so we can tell stories with film, hoping to do that as well. And we need to encourage our patients to tell their stories.
Absolutely.
Brent and I are together working on a new nonprofit organization, which will be a place. One of the things we will do with that new nonprofit is encourage people to tell their stories. We'll record them and make them available for everybody else to see them. What is wrong with the way we're practicing healthcare business in the United States? That every family has a story to tell. Let's help people tell those stories.
I haven't written any books. It's not a goal of mine, but I could probably write a monograph of my story. But instead of writing the monograph, I'm going to tell you my story, because what I want to do for the healthcare professionals listening to this podcast, I think there are single payer curious people out there and closeted single payer supporters. And I want to release some of the friction that's holding them back. But my story begins in high school, and I went to a Jesuit private high school in Phoenix, Arizona. During my high school experience, I had a friend who became a quadriplegic my senior year in a car accident. Shortly thereafter, I had another close friend pass away in another car accident, going to a picnic with his girlfriend. But the Jesuit ideals of men for others, it always resonated with me, and it stuck with me. And that profound emotional journey, it solidified this men for others mentality. And so I decided to go to medical school, went to the University of Arizona. I met my wonderful wife down there, who's a practicing pediatrician in town. We did residency at the University of Arizona, Tucson. We came here in 1998 and started practicing medicine. When I started practicing medicine, I had this cognitive dissonance about costs of healthcare. Who was getting access to healthcare and who was not? But at that time, I was too concerned about being a good orthopedic surgeon and raising a family. So I buried it. I didn't pay attention to it. My sister developed cancer about 13 years ago. And over the course of 10 years, she spun down to Medicaid and she eventually passed away. But I saw the economic toll it took on her in her cancer journey. Over the last decade, when I started to find out, I listened to podcasts, started reading books. I started to become like a sponge, like what is wrong with our healthcare system? And I thought, different points in my journey, I thought, this can fix us, or B can fix us, or C can fix us. And I finally have come to single payer healthcare, reduce inequality, cover everybody, cradle to grave. But my flipping point from my closeted single payer healthcare position to now an advocate came with two non-healthcare books I read over Christmas this last year. One was the memoir by Samantha Power called The Education of an Idealist. And in that book, she graduates from Yale and goes to the Bosnia War to cover it as a journalist. But while there, she says, I no longer wanted to be a bystander. I wanted to be an upstander. So she went to Harvard Law School and became involved in the process to make meaningful change. And the second book is by comedian Trevor Noah, and he's got a book called Born a Slave. But I will read you one passage in there, and this really is what pushed me over the cliff and said, I'm going to do it. It's just a few lines. He says, I don't regret anything I've ever done in my life, any choice that I have made, but I am consumed with the regret for things I did not do, the choices I did not make, the things I didn't say. We spend so much time being afraid of failure, afraid of rejection, but regret is the thing that we should fear the most. Regret is an eternal question you will never have an answer to. What if only? I wonder what would have. You'll never know, and it will haunt you for the rest of your days. I believe I know what's right. My value system does not align with our current healthcare delivery system, and I want to be an advocate for change.
Wow. Thank you so much for that.
Powerful.
That is, I think, the power that we and the impetus that it can provide for us to also realize that, hey, this may benefit us. It will likely benefit everyone. And since we've taken that Hippocratic oath, we want the best for our patients. So are we not, I guess, morally inclined? And this is something we all have to ponder. Are we morally inclined to go with the single payer health care system or to continue on our status quo. That's a really good point you bring up. Thank you so much for sharing your story.
Thank you.
Yeah. And I think it brings up another point. We're going to have listeners who agree with what you're saying and who've been of a similar mindset for years and who may have been kind of in the closet, like you'd mentioned, or we may have people who are adamantly opposed to this. But kind of what you're also proposing is just having more of an open dialogue, talking about your stories, talking about your experiences, which I think is what's really needed. It does feel that in today's climate, just even bringing this up to some people is somewhat of a, I don't want to use the word trigger, but it really can get some people very upset to even propose this because they'll attach titles, labels, and other ideas to it that are different than what you're actually talking about here. So I do agree there needs to be more of a discussion about this. There needs to be more agreement. And, while we're kind of developing this, I think we all are on the same page that the system we have right now is far from an ideal system, very far from an ideal system. And anybody who practices in medicine should be able to see that. And what I really appreciate is, just like you, we sometimes kind of turn our heads to the side, don't look at it because we're just focused on being the best medical provider that we can be. And I'm just going to do the best job I can, and I can't control this bigger monster. I really appreciate the role model that you both are doing, where you're saying, yeah, I can be a physician, but I can also try to influence the greater good. Tell us briefly about your experiences trying to influence the greater system, some of the successes and failures you might have had.
Well, over 35 years of advocacy, I've appeared before many congressional and legislative committees and in the offices of a variety of members of those various houses and senates. I can chalk up some successes in terms of getting people to recognize something that they hadn't before, which, what are the causes of the economic problems that Brent has so clearly outlined? How come we're wasting so much money when in fact we're not actually caring for people the way they should? And it's been great and enlightening to be able to have those conversations. But the main thing that I've run into is the massive amount of influence that what I call the medical industrial complex, which are these massive corporate interests that are making money hand over fist. What I've discovered is how powerful they are. When you're lobbying at the legislature, even for a very small improvement in the system, it's amazing that how quickly the lobbyists will be right there at that legislator's side after they leave you. One bill that I was following in the Utah legislature, I watched every time I spoke with a legislator. Before they'd gone 15 steps, they got hit by the health insurance industry because they were opposed to what I was supporting. So we have allowed a group of corporate interests to own and occupy the space that ought to be for our public's interest. And that is the main lesson. We've got to grow our movement to the point where it's a countervailing force. That's the main thing I've learned.
I continue to try and influence people one-on-one. I start with my medical staff. I try and pick off my medical staff. And then patients I have coming to the office, any opportunity that opens the door for discussion, I try to engage it.
I think it's a good reminder for all of us. And then it's the small things that we can do. And I really appreciate your perspectives on this and enlightening us and sharing this with us and opening dialogue with us, because that's really what we want to do, is open the dialogue between us physicians and hopefully the legislators here. This is exactly what we're aiming to do. So I really appreciate you being on this podcast today.
There are many educational resources for the listeners out there, and they're not obscure. There's a great Freakonomics podcast from 2021 about healthcare. There, Michael Lewis, who wrote Moneyball, A Liar's Poker, he has his own podcast. And in one of his episodes, he talks about finding the expert in your field, and he calls it L6. But what he does is he profiles medical billing and coding. It's fascinating. So there are many resources for education out there. I would encourage everybody in healthcare to please talk about it. There are many things that get our attention these days, climate change, the political climate, but healthcare is something we're familiar with. We live every day and we can influence and make better.
Those of you here in Ogden should invite Dr. Baranko to come and speak to your hospital staff or your grand rounds or whatever. Open the door.
And I have pulled out my closeted single payer supporters. I have them and I know who they are. And we could have a panel and a nice lively discussion.
Well, I think this is a perfect place to express again our thanks for both of you for coming on and talking to us about this. I hope this is just the first of multiple future discussions that we can have. And I'm hopeful in an upcoming meeting of the Ogden Surgical Medical Society, we could have you come back and have a even bigger discussion on this, because I think most of our listeners will find it interesting and they'll also want to express their own thoughts and opinions on it. So again, thank you. And my last question was, how should we direct people who are interested in getting more involved?
So our website should be up and running, hopefully sometime this fall, but there'll be educational materials there, ways to get involved.
As I mentioned, we've started an organization. Our organizational goal is to bring single payer health system reform to the ballot in Utah. It's called Common Sense Healthcare for Utah.
Thank you very much for coming on.
Great, enjoyed it.
I did too, thank you.
So in closing, this has been another episode of the Ogden Surgical Medical Society podcast. We're so grateful for our interviewees today, and thankful again for all of our listeners who allow us to keep doing this and bringing stories and ideas from our community, and keep involved. We'll have another episode for you shortly. Thank you very much.